Hello, preceptors or residents. This discussion education topic is going to cover Journal Club. Did you get a little bit nervous when I said Journal Club? If so, don't be. Don't be nervous. That's why we're going to have this discussion. So I will share my screen and we'll begin the discussion. Sorry, I didn't have my camera on, but it is now. So let's do a screen share and let's jump into a PowerPoint. And I'm going to show you all, I'm actually going to do a journal club. After I record this, I'm going to go through a new article. We're going to talk about it and I'm going to show you how I approach it. And I'm going to show you my template for doing it. So let's get started. Let's share the screen. And here we go. So journal club, what is a journal club and how to perform a journal review? A journal club that's when you're taking primary literature, something just hot off the press, maybe a few years old, but the whole idea is to review it and see if there's validity to it. And if there's validity to it, is it something we would want to adopt into practice at, in our case, United Regional Hospital? Or not, either or. It could go either way. Or is it something that is a trend, ivermectin maybe with COVID or hydroxychloroquine? There are a lot of journals that published articles that supported its use, but were those robust? Did they have validity? And when we finally had studies that had the validity and the robustness, we found that it wasn't something that could be used therapeutically for coronavirus. And it's not a knock at other things. There was just, but a lot of times it is a small cadre of patients, a case cohort, a case report. Those are great, but those are proofs of concepts. We have to do the studies. When you see a positive signal, you have to do a proof of study. How many times have you heard a study showed that in laboratory cell lines, they were able to cure HIV or cure cancer? That is step one, proof of concept. Then you have to try to move that to a smaller cadre, then to the populace, if you can get that far in an approval process of a drug, for example. If you can get that far, can you prove it? And many times we find once we get it into the mammalian person, animal, whatever it may be, a lot of times it's dogs, we see that it doesn't work. And again, you want to make sure that what you're doing or reading is valid or invalid. You're trying to validate something. So the why, it's a discussion. Well, what is it? It's a presentation, or more importantly, a discussion. It's a journal club. You don't go to the club to hang out by yourself. You go to the club to dance with others or to golf with others. So that's the whole point. You want people to interact with you. But we're reviewing, discussing a scientific article, and hopefully, we hope it's peer reviewed. You want it to be a reputable journal that you're looking at. What else? Think about it this way. So keep up with scientific literature, understand, learn about evidence-based practice. And again, don't always believe what you hear. So here's a way to look at that. What if, so back, former CMO, Stephen Fanley at Hendrick Medical Center, he and I would talk often. He's retired now. He was a pediatrician for 40 plus years. And he told me back when he got out of school, he was told by the time you retire, all of the scientific literature will have turned over one time. That was the rate. And last time I talked to him, we discussed this before he retired about 5 years ago. He made the comment that now scientific literature turns over every 2 years. So there's no way to keep up with it. But what if we have 2 residents and 10 pharmacists? What if once a week, one pharmacist or resident took a journal, reviewed it, and presented it? Do you know how that would affect all of us in staying up to date in a passive way? You're just having to listen and discuss, and discussion helps you remember because you're not having to memorize or regurgitate for a test. So what if we did that? So think about that. It may be something we want to adopt. Every 10 weeks, you get to do a journal club, and maybe it's part of your review for annual assessments. Who knows? But it gives us an opportunity to keep up to date with the literature without having to sit down and do these detailed reviews because we know our colleagues are going to take their turn. But we want you to understand as a resident and as a pharmacist, if you haven't done one of these in a while, understand the how of critical scientific review of a journal or an entry or a publication. Again, what I said, my focus is sharing the knowledge with others. The more the merrier. I think when we have journal club presentations, the more pharmacists we can have present, the better. This isn't a presentation to, now a resident is going to get critiqued on it, but the whole point is a resident is for you to be the teacher and we are the student. And as I tell my students at Hardin-Simmons in pharmacology, sometimes the best teacher is the student. In this case, sometimes the best teacher may be the resident. I want you to think about that and appreciate what I just said. A big thing, learning how to agree and disagree. And I'm going to show you the template I use from Rebel EM. I'm going to pull up, and this is actually going to be on Andexanet Alpha, Anexa study. I'm not a fan of that drug. I'm a Kcentra guy, a 4-factor PCC. End of story. But some people will disagree with me, right? So there's different interpretations. Learning how to narrow down an abundance of information and present a journal entry. Can you dig through all the fluff? I like to quote Eddie Vedder here. Never ruined a good story with the truth, the whole truth, and nothing but the truth, so help me God. But if you just scoot a little dirt out of the way, you start seeing some ugliness. You just painted over that, didn't you? And keep that in mind. Did they paint over something that was and I'll show you that was a little bit sinister. And I'll give you an example with the Andexanet Alpha, the Anexa 4 study. The final results finally came out. But again, it's called Journal Club for a reason. You should expect some back and forth. Now, if you presented something, this is your presentation, your review. If someone tells you you're wrong and you feel you're right, it's okay to respectively say, we agree to disagree. That's fine. I expect you are a professional now. You have to learn how to come up with your own conclusion and support it with literature and be able to defend it. Someone else might not see it the same way. Again, Kcentra, 4-factor PCC, factor 4 PCC, or a sham, whatever it may be. That's the discussion you have to have. Now, there is an app for that. If you come across this before you purchase it, I want you to talk to me because I have it. The only thing it's good for is to get an idea of how they set up their journal clubs in this app. They use the PICO method if you're not used to that structure. It's very nice. Go look it up. It's a good way to put studies together too. But I don't recommend this. Why? It was last updated in 2019. And again, remember, Dr. Fanley and I, our discussions, medical science turns over every 2 to 3 years now, where it used to be back when he graduated, it would be the 40-year span of your career. The estimate was things will turn over to one time. Now it's every 2 to 3 years. So a lot of the stuff that's in here is actually outdated. And I'll give you some examples. So maybe good to understand the how, right? This could give you the how to present a journal club. But before you go purchase this, see me and we can pull a study and I can screenshot it and give you an idea of how they do it. I don't want you to go spending money. Now, when you see this, you're probably thinking that's a lot of paper. And you're probably thinking of, if it's me, the first thing that comes to mind is Dunder Mifflin, The Office, Michael Scott, Dwight Schrute, etc. But that's not the case. The point is there's a lot of stuff out there. Get something from a reputable journal, first of all. Get something that will help you, maybe something you're weak at. Don't go for your strengths. You need to take the opportunity to maximize your weaknesses. Second of all, if you pick it out yourself, right here in bold, get it approved by your preceptor, okay? Yes, sometimes you'll pick your own paper. Sometimes the preceptor may assign the paper to you. But if you think something will make a good journal club, make sure your preceptor approves it first. And the second thing is make sure your preceptor has a copy of it. But hopefully you get something that is interesting to you and makes you better. Again, I always say get something that makes you stronger. I'm about to do a lecture series, which I'll share with all of you, over the parathyroid hormone. I always have trouble with secondary hyperparathyroidism, chronic kidney disease, and specifically end-stage renal disease and dialysis as it relates to vitamin D analogs and its effect decreasing the PTH versus calcimimetics decreasing PTH and the effects of vitamin D analogs, VDAs, on increasing calcium and phos and making a detriment to a situation versus the calcimimetics, or a balance in between of decreasing the PTH, the phos, and the calcium. When do I add my binder? It seems so simple, but I have so much trouble grasping that concept as it revolves around the patient with chronic kidney disease. So it behooves me to study it and put a presentation and become the teacher. It's the only way you can get better. So keep that in mind. So anyway, you want a paper that advances knowledge, okay? Positive or negative, okay? Sometimes people do a study and the results are negative. Oh, I'm bummed out. I'm not going to publish it. No, publish it, because we need to know what doesn't work as well. So that's very good. And then it needs to be in line with your current rotation. If you're doing an infectious disease rotation with me, I don't want to hear about venous thromboembolic events. Do that with your critical care, your internal medicine folks. Now, if we're talking about a TAVR and infective endocarditis and septic thrombi or septic emboli, yeah, go for it. I want to hear it. Let's talk. But again, as I said, a peer-reviewed, published paper that has been cited, well-respected journal. Okay, and again, hopefully you're not digging through this many papers, but you get my point. Okay, make a handout. Give us something to hold on to and follow what you're talking about. It doesn't have to be detailed, but bring handouts to distribute to your audience. Even if you're doing a PowerPoint, it helps to have something to hold on to, follow along, and more importantly, make notes. Have a template. I'm going to give you an example of a template shortly, and I'm going to show you how I do it from Rebel EM. We're going to look at that. It's how I like to put them together because I love his format. And it's similar to what we're going to go over, but have a template. And if you don't want to use my template, that's fine. Have your template, but use it. Know it, stick to it, but don't read from it. Disseminate your own words, but it makes it easier for you because it keeps you in line and organized. And you can just have keywords, but it also gives your audience something to hold on to and make notes. But use your own words. Don't just cut and paste. Just summarize what something says and use your own words. And you need an example. And I have this in a hard copy. I just made 2 slides. You can see here. A journal club. What's the name of the article? What was the purpose, right? What's the hypothesis? Give a brief background as to why. If we're talking about the coronavirus, it's the why might be if you meet this criteria, you have an increased risk of mortality or morbidity. And we think this intervention with ivermectin, let's just pick on it, could potentially prevent progression to fulminant respiratory failure and death. But you got to study that. So what was the study design? How are they going to prove it? Was the design and the methods they used appropriate? Was the patient selection appropriate? Okay. Was it 20-year-old males and females in fit condition in one group versus 60-year-old obese males and females with comorbidities in another group? I can already tell which one's going to do well, regardless of ivermectin. And that would be your outcomes and measures. But your outcomes and measures is their bias, selection bias, as we call it. And then how they analyze it. Did they use an appropriate statistical analysis? Did the confidence interval include 1? And they said this is important, this has clinical relevance, and they make it sound like it's statistically significant, but they don't give you a p-value, but they give you a confidence interval. And if it has 1, it's not significant clinically or statistically. Now, in some studies, when we see clinical relevance but not statistical significance, I consider that a positive. And okay, was it underpowered? And is this a proof of concept? We need to take this to the next step, okay? Ivermectin, it was showing a little bit of positive trends. But when we took it to the COVID out study of fluvoxamine, metformin, ivermectin, hydroxychloroquine, we found out that no, unfortunately, it didn't work. But you can go through the rest of these and see what you want, study strength, study limitations. So I'm going to break out of the slideshow right quick, and I'm going to show you the template I use. I think this is a good time to do that. Okay, so I'm going to minimize this, and I already have it pulled up right here. So Rebel EM. And if you go to Rebel EM's website, he has a lot of good stuff, but you can go to his, I think it's here under his reviews or his critiques. It may be one or the other. But I want you to look. This is the one over in DEXA, the INEXA study versus four-factor PCC. So the ongoing debate. So you can see here, this is INDEXA versus four-factor PCC and intracranial hemorrhage. And he gives the background. And I like how he does this. He explains what's going on. And he gives the article right there in the clinical question. Compared to four-factor PCC, is Indexedin alpha safe and effective for the reversal of factor 10A inhibitor-associated intracranial hemorrhages? And to answer that question, the answer is yes. We proved that it could reverse factor 10A activity, but did it have a benefit, a mortality or morbidity benefit? That was the question we still needed to be answered as it was compared to Kcentra, the 4-FPCC. That was the problem. But you can see here the way he does it, and you'll notice this is how I do mine, what they did, what was their population. But it's very important to understand when you look at what they did and you look at the population, is this standard of care? Did they create a bias? Is there an intervention bias? Is there for example, when you look at your 10A inhibitors, was it a disproportionate share of rivaroxaban versus apixaban in the control group and the treatment group? In this case, it was two different treatment groups, but you see where I'm getting at. Because one's not the same. I can give you some example where in valvular heart disease, apixaban is better than rivaroxaban and certainly dabigatran. So you got to look at that. Is it appropriate? Was their exclusions appropriate? Did they just keep people who were well? Well, we only kept people in the study who had a Glasgow Coma score of 10 or higher. Come on, they're going to survive. You know that. So that tells me right there. But keep that in mind. But then the intervention, the comparator, the outcomes, the results. You can see how he goes through this. This is very nice. Yours doesn't have to be this long, but then he gets to the end, and what's the strengths of it? But what's the limitations? And read through something like this. He has these riddled through. He does these all the time. And then there's the discussion, and he calls it the rebel rant. And the first thing, this is not a randomized controlled trial. It appears to be more bad science hidden behind complex statistical methodology. I love it. I love it. I'm not a fan of Indexedin alpha. But you can see here when he goes through it, and then of course propensity score matching. Ooh, that's the way you can take sometimes retrospective trials and say, well, we did propensity score matching, which it's a fancy word for saying, it's like when you see a subgroup analysis, that makes me think that means you didn't meet your primary endpoint. You're chasing a red herring. But it's things you got to look for, and propensity score matching. When I see that, okay, yeah, well, we're gonna if you assume this, you would have gotten this. And now tell us what the studies do. But you can see here as he goes through it, I love it. And now he goes into a lot more details. But I love how he puts this. And there's one, and he even talks here, he talks about the confidence interval. So you can see here, crosses one. Ultimately, the small sample sizes and wide confidence intervals make us skeptical of the findings. And so you got to be careful, because this drug, okay, if you need to reverse, you need a mimic, because that's what it does. It just binds it, then it releases it. I mean, this is only about a 4-hour duration of action. It doesn't neutralize it. It just binds it, and then it lets it go in about 4 hours. But is this something at a high cost, maybe more than Kcentra, we want to use? You got to weigh the risk benefit. Okay, do more people who get Kcentra have thrombotic events because we shifted them from a bleed to now anticoagulated to hypercoagulable? But that gives you a good example of what I'm talking about. And again, if you're not familiar with this is great. It's Rebel EM, a lot of good stuff. Look, amiodarone versus DIDs for acute rate control, all kinds of stuff. I mean, I get so much good information. So see all his posts, but yeah, you need to go through that and you need to appreciate that. So let's get back on track. And nope, that's the Hardin-Simmons, the class of 2025, which isn't my issue anymore. So Journal Club right there. Okay, so there's the example though. I have this, I can email it to you. You can make your own template if you want. Okay, so what's the general overview when we're doing this? When you're presenting a journal club, you're going to give an introduction and the study design, the population, the data analysis and the study outcomes and the conclusions, right? And you can do it as simple as that. But here's the key. Here is the kicker to this. And this is the most important part. What I want from you, whether you're a pharmacist or a resident, I want your opinion. Once you complete it, then you should give your assessment of the above. And don't try to and don't be intimidated by who's in this. You're the teacher. And yeah, maybe you learned something. Maybe someone points something out to you, but it's feedback. It's just formative feedback. You're not going to lose points for it. But you know what? You're going to be better. And that's the whole point. I want to emphasize that again. The whole point of this is for you to be better tomorrow than you were today. And so this is an opportunity for an opportunity. But you also have the opportunity to make me better because I'm going to be listening to your journal club. And I want to hear what you have to say. I haven't read this, and I don't want to take the time to read it. And I'm grateful that you're going to be the educator. So when you do these, you need to make sure you just don't halfway do them because people may take what you say and put it into practice. So keep that in mind. It could go from your lips to the patient's body. Okay, so how? First advice, these aren't the two questions. These are two questions here, but just think about it this when you're doing this. Is the study reliable and is it reproducible? Okay, we know that ivermectin is working, and then the next 10 studies weren't reproducible. So really the first one was just a proof of concept, and the rest of them disproved, but all the studies were horrible until we did COVID out down in Brazil. I thought that was a pretty robust study, actually. And I'm a fan of metformin over Paxlovid. If you're wondering why, find me. Okay, so the two questions, though, that I mentioned is how will you or you will not adopt the material presented into your practice? Number two, if you were to repeat this study, what would you do differently? Those would be some of the weaknesses or biases. And so if you're going to adopt it, tell us the why, define the why. And if you were to repeat this study, what would you do differently? That means you found a potential weakness. So you have your strengths and you have your weaknesses. There you go. Easy as that, right? But follow your template. Tell your story of your paper or the paper you're reading that someone else wrote. But this is your story. But you have to appreciate and you have to understand what you're talking about. And what I mean by that, if the context of your study is a subarachnoid hemorrhages on patients taking DOACs, specifically 10A inhibitors, rivaroxaban and apixaban, you have to understand what a subarachnoid hemorrhage is. You have to understand what 10A, what factor 10A plays in the intrinsic, extrinsic clotting cascades. You have to understand additional pharmacotherapy that may be part of that. Well, were the patients taking aspirin as well? Because maybe that caused an increased expansion, or because they were on aspirin, we didn't see a 35%. So should we be given tranexamic acid? And you can start getting into those discussions so you can see how it can get very detailed very quickly. And that's the problem with studies is sometimes their exclusion is so specific and so strict, they exclude what the normal populace would look like. Some people will be on a PGY inhibitor, your Plavixes, your ticagrelors, you know the drugs. Is it P2Y12 inhibitors? Kind of get off. Or are they taking an aspirin? So is this a thromboxane issue? Those are the questions you have to ask if that's the context of your discussion. So know the context, and you must know the background and or the guidelines for the topic of choice, including additional pharmacotherapy. So yes, you may have to study. Welcome to pharmacy. You should study every day. But again, remember, I've said this now at least 3 times. If this was a test, it'd be a test question. The reason we're doing the journal club is to make you better, but also make your audience better at what they do. So embrace the opportunity. You get a chance to make a difference. How many people get to say that when they go to work each day? You get a chance to make a difference in someone's life from a health perspective by presenting. And it may be we need to avoid this like the plague. Again, if that's the case, you just kept a patient from getting a drug that could possibly be detrimental, right? A bunch of antipsychotics and QT prolongation on top of diphenhydramine which prolongs the QRS. It's a sodium channel blocker at high doses. Everybody says an antihistamine, it's benign. It's an antihistamine with a bunch of off receptor sites is not benign. Okay, so how? Step one, general information. This is a good way just to start. Just read through I like to read through the journal entry one time first, straight through. No stopping, no highlighter, no pen. Just read it. So when I said use a template, use it. But at first, just read what you're doing. And maybe if you're going to take notes, do a nice, easy background. These 5 simple questions: who, what, where, when, and why. So who, for example, who published or who participated? So for example, this is a study, say it, over XYZ published in the New England Journal of Medicine of 350 subjects were randomized in a 1-to-1 fashion in a double-blind placebo-controlled trial. The who, the what was the intervention? 125 subjects were assigned to the control group, with 125 subjects assigned to the treatment group that were diagnosed with COVID-19 in the past 3 days with symptoms for no more than 5 days. Where did the study take place? This is important. A single center study is not going to be as robust as a multi-center study. I want to use the Malik study. If you remember, the Malik study said high-dose thiamine, vitamin C, and hydrocortisone decreased mortality in patients with septic shock and sepsis. But when they did a robust multi-center trial, they found out that wasn't the case. And now they found out that those who were in the treatment group are having more cognitive issues post-sepsis. If you want those articles, I can get them to you. So that's important. The when, or how. So how patients took a placebo or drug X, Y, or Z in a blended fashion at 100 milligrams daily over 1 hour for 3 consecutive days. Patients were followed for day 1, 2, 3, 7, 14, 21, and 28 for a primary outcome of resolution of fever, COVID-19 symptoms, emergency visits, and hospitalizations. A secondary outcome was death. Now, when you see that, to me, this study is already junk. If you have more than 1 or 2 primary outcomes, that's too many. What you have too much wiggle room to start doing these post hoc analysis and cherry picking. Well, we had resolution of fever, but the symptoms didn't get better. And the second thing you got to look at is, what did they define as fever? What did they define as COVID symptoms? Was it something that the physician, it was their perception of it? Because if that's the case, you now just went qualitative. If you have true symptomatology and you meet it or you don't, to me, that's more quantitative. And I can do it in a 1, 2, 3, 4 table. And then I can start using statistics such as the mean, median, and mode. And I can start going that route, or ordinal versus nominal, right? Or continuous. Emergency room visits. Well, was this a 24-hour ED, which is more of an urgent care clinic, or a true ED? But look at all these. There should only be 1 or 2, maybe death or hospitalization. Everything else can be a secondary. And if you don't meet your primary outcome, when you look at it, don't even look at the secondary. The study's junk. Well, it's not junk, but just know it's all been debunked. I shouldn't say that because it tells us what doesn't work. But then the why the study was done. And the study was done to see if XYZ is an effective treatment for patients diagnosed with COVID-19 in the last 5 days. So start with this: just who, what, where, when, and why. And this kind of gives you an idea where you're going. And that's what I do on my first, and I'm telling you how I do these, but I do a 1 read all the way through. Now the population, this is very important. So the population section in a journal club discussion, it should cover the characteristics of your study sample. And that can be demographics, any exclusions, inclusion. You're trying to generalize the populace. That's what you're trying to generalize. So you got to make sure, if it's a study on aromatic amine anti-seizure drugs like carbamazepine or phenytoin or lamotrigine, and they're looking to see who had a DRESS-like skin reaction, drug-related eosinophilia with systemic symptoms, which can be fatal, that progresses to multi-organ dysfunction. And then from a skin perspective, you get a toxic dermal necrolysis, Stevens-Johnson's. But what if, from a race perspective, it was all Japanese. We know that they have a higher risk. So what if one group, the treatment group, had a lot of Japanese and the other group had a lot of Scandinavian Caucasians? Well, that's where pharmacogenomics comes into play. Yeah, you're going to see more reactions. And with carbamazepine, there's a certain subset of the population, including Asians, where we do some HLA testing. We do some antigen testing to make sure that they're not, from a pharmacogenomic precision medicine perspective, more susceptible to that adverse effect, that syndrome. So those are the things you look for. Is there discordance? That's what I'm trying to say, between age, gender, comorbidities. If it's the COVID study, if the inclusion group all had COPD versus the other group, I mean, you see what I'm getting at. But it's very important, okay? So, and again, I put disease being treated. I'd expect better results in a 20-year-old with COVID versus a 90-year-old. But the list can be long. But does it represent the populace? Especially, does it represent the populace that we're treating? And studies are doing better at this in bringing in more racial, I guess it'd be equity, equality in the study. Because, for example, let's take African Americans or just blacks. It doesn't have to be African Americans, but those who of color. Calcium channel blockers tend to work better for blood pressure than ACEs or ARBs. So if you don't have a confounding indication such as diabetes or kidney disease to be on an ACE or an ARB instead, you'd really want to do maybe some hydrochlorothiazide and a calcium channel blocker. And that gives you an example. We wouldn't know that if we didn't do studies that include multiple people of different races and backgrounds. So that's important too as well. So look at that part of the populace. So if 100% of the participants were Hispanic or white or Asian, you can have pharmacogenomic differences among races. So that's something to keep in mind. Very important. Okay, step 2, eligibility. The eligibility section of the Medical Journal Club. Meetings should cover the exclusion and exclusion criteria for participation in the study, as well as the criteria applied to select the sample. So review this closely. Again, I think I mentioned this. Patients with COVID symptoms, did the authors define symptoms or was it at the discretion of the provider? And I like to say if it's at the discretion of the provider, you just introduced bias. Because it's qualitative, it's not quantitative. If you have a cough, you have a cough. Well, you just coughed one time. It's probably your ACE inhibitor. It's okay, man. You're cool. Nah, I don't think so. Were other therapeutic interventions defined as exclusions? Patient with ivermectin for COVID. Picking on ivermectin today. But they also were taking metformin. And we know metformin actually has a pretty good looking benefit in COVID out. Now that study got buried. It's New England Journal. It got buried because by golly, we're going to go with Big Pharma Paxlovid. But I'm just saying, again, if you want to discuss that study, I'd love to discuss it with you. And you can disagree with me. That's okay. Was the criteria of the study, was it in line with evidence-based medicine? Was it best practice? If they're looking at the rate of VTE and the normal dose is 40 milligrams daily of Lovenox, but let's just give 20. And this group has more DVTs than the other if you're comparing it to some new pill or rivaroxaban. But yeah, that's great. You showed that rivaroxaban was superior to Lovenox, but you gave 20 milligrams daily. You gave them 50% of the, you got to look for that. You got to look for it because it's there. It's real. Step 4, methods. This is what I like to do. I like to make a graph or a chart or a flow chart. So the methods section of a medical journal, this is going to cover your study design, the data analysis, the outcomes, and any applicable conclusions. So consider a flow chart for their methods. How did they get to their conclusions? They're not going to necessarily give you their conclusions, but they're going to give you the methods they used to determine good or bad. Okay, so sometimes it's technical, and keep it simple. I like the KISS, keep it simple, stupid. That's what I do because I don't consider myself stupid, but sometimes I can be pretty ignorant because I just don't know. So I'm asking for me, when you think of KISS, you can think of me, picture Greg, and please keep it simple. And I think most of us will appreciate that. The methods can get, sometimes there's a lot of smoke and mirrors in the methods. So keep that in mind. That's why I like to tie it all together. It's like, wait a minute, we just went in a freaking circle. What are you talking about? But if you don't map it out, you might not realize it, and it sounds really cool. So step 5, outcomes, results being studied. So the outcome section, what is that? That should cover your primary and secondary objectives or outcomes of the study, and as well as any outcomes derived from statistical analysis. Now, be very careful when you see post hoc analysis. Subgroup analysis is good, but when you do post hoc, that tells me they went in after the fact and they dug through some stuff and created a situation where, hey, this is beneficial. Well, you should have defined your study the same way your post hoc analysis. You can't go redefine your, and this is what gets me. You'll see a study, you'll go on clinicaltrials.org, and then you know what? You changed your primary outcome halfway through the study. No bueno, that's not good. No, 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 no. But let the audience know what the primary and secondary outcome targets were for the paper. And remember, if you start having a list a mile long of primary outcomes, just trash it. You can't do that. It needs to be a primary outcome, and then you can have several secondary outcomes. But it's like I tell my students, if my students have 5 things they're doing wrong, I pick the top 2 or 3. And we'll talk about that today. Usually just the top 2, because when you get to 3, 4, and 5, you've lost them. They're overwhelmed. But if the primary outcome isn't reached, and I think I mentioned this, pretty much you can ignore the secondary outcomes. So we talk about reached. Next slide. Step 6, statistics. This is something I'm weak at. I've been a pharmacist now, as I make this, for 28 years, and I still carry an ASHP cheat sheet. Very simple, but I'm a big fan of like positive predictive value, negative predictive value. Some of you may have talked with me about patients who come in with pneumonia and they get put on MRSA coverage, Vanco. And I've mentioned about getting a PCR nasal swab. If it's negative, that has a negative predictive value of over 95%. So if it's negative, odds are, very strong odds, you do not have staph pneumonia. And you put that into the context of a chest x-ray that's not cavitary in nature. You put that in the context of you get negative blood cultures, no growth to date in 24 hours. You can DC your Vanco, right? But what if it's positive? Now seen on the opposite, it's positive. So I need to cover for MRSA Vanco. Well, what if I told you the positive predictive value of a positive MRSA swab is less than 50? Less than 50%. It doesn't correlate. Doesn't correlate. There's no causation, maybe some correlation. I don't even know that. We could do a Pearson's correlation coefficients and see. But I think you get my point. But I also like things like numbers needed to treat, numbers needed to harm. Ways statistics can fool you is mean, median, and mode. They're not the same. Those are the measures of central tendency. Keep that in mind. But numbers needed to treat, numbers needed to harm. That tells me a number. If any of you read my spiel on the new study that came out just today when I record this from New England Journal of Medicine of severe CAP and hydrocortisone, if you looked at the numbers needed to treat versus mortality, you'll see what I'm talking about, how I put it into play. But you can also do numbers needed to harm. They give you a percentage, but they say a relative risk reduction. That is taking the difference between the percentages, but I want the absolute. The absolute is we went from 5% to 4%. If you do relative risk, I think you're going to, oh, it's a 20% reduction. No, it's 1%. It's relative. But if you're having trouble, I have a very nice handout that I can, this is a link. You can use that. You can click on it. I also have a very nice handout. I have multiple handouts, and every time I do a literature review, I pull it out. Okay. Now, the handout I have from TLDR is several pages long. It's about 30 pages long. You don't have to go through all of it, but you could certainly go in there, pick and choose. But anyway, let's move forward. So the statistics section of a medical journal club, what is it? What are we talking about? This is going to be the discussion of the statistical methods used in the article. And were they appropriate, right? We want to talk about appropriateness. We always want to do that. Then discussion of the meaning of any findings associated with statistical analysis. Now, you might see that it's not statistically significant, but there may be some clinical relevance. At that case, you got to start weighing risk benefit and go from there. But proof of concept, but you got to understand it. But again, I put in here, we could talk about this. Well, they have whole semesters talking about 2-hour courses on statistics. So we could go on and on and on, but just know I can't rattle the stuff off the top of my head. I have my handful of things that I can do in real time at the point when I'm looking up something on Google and I need something fast. I can do that. But when I do my actual journal club to look at to dig into the details, right? I pull out my cheat sheets, and there's nothing wrong with that. I'm not a statistician. And you know what they say about stats? What is it? Lies, lies, and damn lies, or something like that. It's kind of the truth. Stats, you could contort these things any way you want. But again, when you see post hoc analysis, that means they massage some stuff out. Step 7, the results. So we're getting towards the end. The results section of a medical journal should include an overview of the study's results. So what it's saying, a discussion of the implications and any relevant limitations. So you're talking about the results, and this is when you start getting into validity. Are they valid? And that's when you can start discussing your weaknesses and your strengths based on everything you just reviewed. So the strengths and weakness section of a medical journal club meeting should include a discussion of the various strengths and weaknesses of the research, such as their methods, how they analyze the data, interpretation of results. And remember, when you frame that interpretation of results, and it's easier said than done, trust me. And this is where I'm digging through, okay, I don't even know what. An analysis of variance. What is that? Well, that's why I got my cheat sheet. But you got to frame it in an analytical manner, constructive, that can contribute to the dialogue. And more importantly, the understanding. And that's when you're trying to bring full circle to your audience. Was this a good paper or not? And why? What, when, why, where? We talked about that, the first slide. Now you're bringing this full circle so you can appreciate it. Step 9, the discussion. I don't expect this just to be you sitting there twiddling your thumbs, doing all the talking, or people sitting there twiddling their thumbs while you do all the talking. It's a journal club. So you're going to have a discussion. Yes, you're going to give your assessment of the main points of the article that you just went through, but you want to analyze if someone gives you some disagreement or there's some discussion, have it. And this is where you can get in discussions from a clinical perspective, the population implications. Is there any ethical issues with this? Right? And then those implications of using it or not using it. And sometimes that could be culpability, liability, lawsuit. So keep that in mind. And I put in here in bold, in addition, this section should provide a platform, and this is where I want to get to, for open and critical dialogue concerning the research, its methods, and any related subjects. And someone will probably disagree with you, and that's the beauty of medicine. But here's the thing that's great about it. They're probably going to tell you the why. I disagree with what you just said, and this is why. And you might not agree with them, but guess what? What if they say something and it's like, I didn't think about that. That's the whole point of Journal Club. Hopefully we can come together as a team. And in medicine, I hope we're working as a multidisciplinary team. We're working together. 1 + 1 is 3, not 2, 3. When we work as individuals, 1 + 1 is 2. When we work as a team, it's synergistic. It's more. The sum of the parts is greater than the whole. So, conclusion. All right, we're done with it. This is when you're going to conclude. We're done. Just give a summary of your key points and summation of the findings, the main context of the article. Give some more recommendation. This is kind of bleeding into some of the previous slide. And talk about recommendations, implications that need to be drawn from the article. Do we need to adopt this into formulary? Do we need to change a protocol? Do we need to change a process? hey, we need to start, instead of using PTTs for heparin monitoring, we need to go to anti-factor 10As. And someone asks you in P&T meeting, why? Now you have the why. So you take it to a bigger audience. So it can actually encourage change, implementation of change for the betterment of the patient. And a lot of times what we do in pharmacy is the S word for safety. Okay. But again, open invitation for discussion and open invitation for criticism. Don't let your little feelings get hurt. Don't do it. This is medicine. We're talking about it. We're talking about a human. If we were digging a ditch and you didn't like how someone was digging it, nah, it's not going to hurt anything. Just let him do it. You're right. But if we're talking about a human being and you see something that if the intervention is carried out could potentially hurt them, if you do not intervene, shame on you. And if the person you're intervening on doesn't like the criticism, shame on them. But be tactful and finesse. Okay, tact and finesse. Anyway, Journal Club. Closing thoughts. Watch some Journal Club presentations before you do it and practice yours. Simply Google YouTube Medical Journal Club presentation. You're going to find a ton of them. And this is a nice one. This is a nice 10 tips for presenting the Journal Club. Again, really nice. And it's only 10 minutes in length. So give it a look. Okay, so I'm going to back out of this right quick. I'm going to keep sharing, but I'm going to show you something that I'm going to do a Journal Club on. And today's March 22nd. So if I can find it, here it is right here. This came out actually last night. I have not done a one review, but this is hydrocortisone in severe community-acquired pneumonia. I've only read the abstract, but I can tell you by looking at this, because I did the math, you can see here, if you look at it, death was decreased from, where was it? It was in there. I don't know. The numbers needed to treat. I don't see the extra. I'm not going to waste your time digging through it, but I got a lot of questions already just reading through the abstract. So this is one I'm going to do, build a journal club up, and I'm going to video myself like this, presenting it. But hydrocortisone in severe community-acquired pneumonia. Right now, when I'm looking at this, my thought is already biased, and I don't agree with this. I need to read, though, and see exactly what they did and see the population, how they defined it. But you can see, I will go through this. I will print it. I will read it. I do not like reading from the screen. I like to hold it in my hand. Plus, this hurts my eyes. There's a nice way for methods. I was talking, they did it for us. You can go through and look and see randomization. Did they throw out everybody who was going to die? Now, I hate these 28-day mortalities. Well, those who did survive, were they comatose, bedridden in a nursing home? Or did they actually have functional lives? But characteristics, this is the stuff I'll look at, but I'll read through it first. And then I'll go back and do the critical analysis. Be real careful on these Kaplan-Meier type curves. Look at the numbers. Sometimes they'll do them. They'll do wide numbers and like 80, and then this will be 90 up here where 100 is. When they do that, you get this real nice differentiation of these two things when you have the bifurcation, and you start thinking, what? So percentage of patients. So be very careful. This is in increments in 10. It looks good, but what if it went from 10, 50, 100, you're going to have this huge wide gap. And just by looking at it, this is awesome. Look at confidence intervals. That's one thing I look at. Okay, hazard ratio 1.33. If you don't know what that means, you want to look at that handout I have. Confidence interval, remember, if a CI equals 1, it's not statistically significant. You can stop right there from a statistical perspective, but you can see these. But I'll go through these and I'll try to dig out. I already have a lot of questions in my mind before I've even read this. And I just want to know. I want to know. But I'm going to actually do a journal club on this. So I hope you found this educational. This is the first of the series of how-tos for residents, and this is also applicable to pharmacists as well. So I hope this is beneficial. You know, I know a lot of you have some apprehension on being a preceptor. I know residents have apprehension on doing journal clubs, but no, I'm here to help. Your mentors are here to help. Just reach out. This is fun. This is fun. It's not a punishment. It's fun. So anyway, I hope this is beneficial. And if you have questions, you know where to find me.